Yeah, so thank you everyone for coming. For those that don't know me, my name's Tori and I'm president of Headucate this year, and it's a pleasure to see all of you. I'm a fourth year medical student at the moment at Norwich Medical School with University of East Anglia. So this is important to me as a medical student, and I think you'll hear from loads of other people today why it's important, so I will not talk about that. I'll just give you a little introduction about Headucate for those that don't know. We are a society run by students from all courses at University of East Anglia with the aim of raising awareness about mental health and trying to decrease the stigma that is associated with it. And with that, also educating people. We go into secondary schools and primary schools now and run mental health awareness workshops with them. And yeah, now we do more work with university students. And yeah, we're here with you today. Feel free to follow us on social media on the platforms that are above, and feel free to tag us in anything relating to tonight because we love to hear about it. So it has been Eating Disorder Awareness Week from earlier in March 1st to the 7th of March. So this is kind of leading on from that. And if you haven't already seen, Headucate took part in the Ballet Club's Love Your Leah campaign, which is a body positivity campaign, where we had loads of pictures of our members in leotards and swimming costumes, etc. And we've been raising money for Beat. And we also interviewed a few people about their stories and their experiences around eating disorders. And you can find information about all of those on our social media. And we've also got coming up in May a weekend conference, 2 days, and we've been planning this for over a year. We hoped that we'd be able to do this in person, but yeah, it doesn't look like that will be happening. It's going to be online. We've got an array of speakers and we're going to be sending out packs to all of the UK based attendees, and it's set to be really amazing time. So yeah, do get involved with that. And yeah, as we said, we're raising money for Beat. Even though Eating Disorder Awareness Week is over, that doesn't mean that we should stop fundraising and raising awareness. And we're so thankful to Jess and everyone that was involved in creating the training. You'll hear from all of them today, hopefully a little bit. They'll introduce themselves at some point. And yeah, so please do donate if you can. We're hoping to raise as much as we can, as well as spreading this awareness. So we've kind of started the icebreaker a little bit. So if people have already, feel free to add on to the Mentimeter where you're joining us from. And yeah, we'll also be giving out certificates for everyone that completes the whole training event, but please wait until the end for information about that. We just have like a very small feedback form that we'd like everyone to fill in, just so that we can approve on any events that we do in the future. And just to make a quick mention that talking about mental health can be a sensitive topic sometimes for people, especially when you might have lived experience or someone in your family. So feel free to take some time away or to talk to a family member. We've put up the Samaritans number as well. For any UEA students, Norwich Nightline is open from 7:30 every evening, and they have an IM messaging service at the moment. But there are also Beats services. So yeah, they also have their phone line, and there is like a specific one for students, and there's also web chat and email service as well. So please do seek help if this is something that you think might affect you. But yeah, I don't want to talk for too long. I wanted to leave it up to the experts. So before we hand over to Beat for a little bit, I wanted to have a little bit of an introduction, I guess, to why this is important from one of our local psychiatrists. So I'm going to introduce Dr. John Wilson, who works with UEA and Norwich Medical School and in the local area. So yeah, thank you for joining us.
Can you hear me, Tori? Good. Thank you, Tori. It's my great pleasure to spend 5 minutes just introducing this area. Tori's going to be a couple of things to talk about, but I particularly want to support Headucate because I think they do a fantastic job, and in particular Beat, who I've been a big supporter of for some time. I'm a psychiatrist in Norfolk and research director, and I work at the Norwich Medical School, in the local mental health trust, and the local specialist eating disorder inpatient unit. So I've got about, I don't know, 17, 20 years of experience of eating disorders from a range of severities, really. And one of the things Tori asked me to talk about was why I work in this area. And I think as a consultant psychotherapist and psychiatrist, it's particularly interesting because it spans a number of themes. And on the one hand, you're talking to specialist gastroenterologists about blood results and things I don't quite understand despite being a doctor. On the other hand, you're talking about other conceptual things around eating. For instance, we've done research around feminism and eating disorders at UEA, which means it's intellectually it's never dull. It's always interesting, and the psychotherapy fits very well with the medicine in a way in the rest of psychiatry doesn't happen really quite so often. It also generates an enormous amount as a topic of anxiety amongst clinicians and families, and frustration, I have to say, if we're honest. So why are events like this, do I think they're so important? I think there are still so many misunderstandings amongst professionals about eating disorders, some fears, some very strong opinions, some very different approaches which are taken by different individuals, which often leave people suffering from all the different eating disorders somewhat bewildered or stuck or at loggerheads, I think, with the services which are trying to help them, or their families, I have to say. And these different approaches can be not just at loggerheads, but they can be counterproductive when you put them together. I mean, eating disorders, I think, are so common, but at one end of the spectrum, we talk about them as health and healthy eating, and I've come across hundreds, thousands of people who've got into eating disorders or becoming through trying to be healthier and trying to do things to look after themselves better. And for some reason, it's got out of control, and either they, or more often other people, think it's a big problem, and they lose the ability to control it themselves. It takes control of them. I think another reason why eating disorders are difficult, really, for professionals to understand, is the diagnosis really just describes a range of behaviours or attitudes which are present, and we can ask you, are you trying to actually lose weight, yes or no? But it doesn't tell you why you've got there. It doesn't tell you how you ended up in that place. And I've increasingly think there are so many different routes in different sorts of eating disorders. For instance, someone could be very obsessional. They could be trying to manage unmanageable feelings or complex personality issues. They could be trying to manage family conflicts. They could be worrying about societal pressures or even maturing. Or they could be very perfectionist. And all of these are different routes in and will require different understandings and solutions. So although we have stereotypes about eating disorders, I don't think anybody really fits that mold perfectly. And that makes it very hard to know what to do for professionals, because the evidence base for how we should treat eating disorders is pretty poor, I think. There's a recent Lancet article in Lancet Psychiatry this week, which showed that the nice evidence-based treatments are not superior to treatment as usual. But it also shows that treatment as usual is quite effective, which makes it hard for us to understand whether my treatment or my offer is better than somebody else's, or I should be pushing what I think more than somebody else. I think that really shows the limitations of our understanding. And finally, Tori asked you to speak a little bit about any tips about working with eating disorders, didn't you, Tori? I think obviously as a doctor, you've got to attend to the basics. You've got to be thinking about safety and bloods and those sorts of weights and refeeding syndromes and things. Although most often the people I treat or try to help are not that worried about that. They're worried about other things in their lives. And then I think we've got to try to understand why, as I've just said, that behaviour or that particular style of coping with eating is there, and what's making it stuck there, and why won't it go away? What function might it serve? Before we can start to focus more about what will recovery mean, Hope spoke very well at the last of these seminars. Really, I thought I was impressed really about how she talked more about the journey of recovery and the internal battles that people go through. And it's more like an addiction model in some senses. Some units take that approach: motivation to change, reason to change, faith in being different, some sort of trust that things will be different and that I can still feel in control of myself. And I think it's about thinking about the whole person rather than focusing on the behavior or the calories. Those are really important things, but you can miss the bigger picture by focusing on them too much and get easily into this battles of control, which are really quite counterproductive and stop us working collaboratively with people suffering. That's what I wanted to say, Tori, if that's okay. I don't want to take up too much of the evening. I hope that's set the scene really for my take on why I think we should be having many, many more of these sorts of events.
That's great. Thank you so much. Yeah, I think it's like important to kind of hear from, you know, someone from our medical school as well, why it's such an important thing. Something that we had on a lot of our advertising for the event was that a study showed medical students have I think it was like between 2 and 4 hours of teaching on eating disorders within the curriculum, like throughout their whole 5 or 6 years at medical school. And I mean, there's a lot of discussion about, okay, what would you like replace or what's not as important, but I think what you said about, I mean, the fact that it is so common and the fact that it affects people so drastically means that it should maybe have more time. Yeah, so thank you for joining us so much. We're going to move on. Oh. So now we're going to get into like the main bulk of the evening, because we weren't sure how many people were joining us. So this platform, we weren't sure if it would hold enough people, etc. But I think the way that we're going to have to do it, we'll talk about it in a minute. I'm gonna stop talking for a little bit, and I'm gonna hand over to the team from Beat and Dave Chawner, who is our actor. He's a stand-up comedian and author, and he's going to be doing some of the acting with Alice, who is a 5th year medical student who's on placement at Beat, and they're going to do a little scenario. But first, I'm going to hand over to Jess to do a little introduction.
Hello, evening everyone. It's just so great to see so many of you here this evening. Tori, thank you for that fab introduction. I just have to give a shout out to Tori. She is incredible in raising awareness of mental health. She's astounding, so please everyone give her a big cheer as well for this evening. And Dr. John, that was just such a great summary and introduction to this evening, and already highlighting the challenges of working alongside people with eating disorders. So we've got a fun-packed evening for you this evening. It's going to require some boldness. I'm going to say that now so you can prepare yourself. I've got several members of my team here, so I'm going to talk through in the introduction a little bit how this medical training package came about, but you're super duper lucky this evening because you've not only got another consultant psychiatrist here, Dr. Kieran Chitale, you've also got another doctor who's Dr. Ellen, who is a foundation stage doctor with lived experience of an eating disorder. You've got Dave Chawner, who is a stand-up comedian, but actually, I don't know what he would call himself, like a patient simulation expert. That's what I call him. And he's going to be role-playing the scenario of Alfie today. And then we've got the amazing Alice, who's a 5th year medical student, who is, I am so impressed with, because she's going to put herself out there and do the first kind of role-play for us. So she deserves a big cheer too. So as I say, we'll be around this evening. We're going to be around in the breakout rooms when you guys have a go at the role-playing, and yeah, we'll be part of the discussion time too. So who on earth am I? I'm Jess Griffiths. I am the clinical lead for Beat, and I've been working with Beat only actually employed for over the last year. I was one of their clinical associate trainers since, I guess, 2015. And I'm a trained therapist working with people with eating disorders, and I have lived experience too. So a lot of how I train, I kind of try and bring both sides of the coin. I know what it's like to have an eating disorder. I had all 3 eating disorders in different phases from the age of 11 to 21, made a full recovery, found it very hard, and I'm very passionate in seeing people get well. So I do bring that aspect into a lot of what I do. So if you haven't heard of Beat, please do go and check them out at some point. There are so many resources on there that are useful. We've got information for friends and family, ways on how to speak to someone with an eating disorder. We do lots of things around campaigning. So as Tori very helpfully said, we're looking at this issue of medical training in medical schools, and actually some of the research is coming out saying actually doctors only get 1.8 hours of training, and when we looked at surveys, it's so limited in regards to resource, but it is such a common mental health issue, and so we really believe it deserves a lot more time and space to be explored. And I think the very fact that we have this amount of people joining us this evening just shows actually the willing to learn about eating disorders. It's fantastic. So a bit, yes, we absolutely campaign for positive change. So you'll see us in Parliament, you'll see us raising awareness. We have MPs who support us, and we also get involved in a lot of research as well. And as you heard from Dr. John, there's not lots of great, evidence base in regards to anorexia nervosa. So we're always championing more research to take place. We do a lot of awareness training. A little bit of that has gone to the wayside due to COVID, but we're moving everything online as swiftly as we can. And our help finder actually is a particularly useful thing to look at. It's under our support services page on the website, and you can type in your postcode and it will just give you any eating disorder support groups, eating disorder services that are close by to your postcode, so really useful. And then obviously our helpline is brilliant. We've got online support groups and message boards, and actually we've really stepped forwards over the last year due to COVID. For some charities, I know it's been really hard. For us, we actually have accelerated far beyond our wildest dreams this year. We've got some funding from the lottery to actually be able to deliver services specifically for binge eating disorder, for bulimia nervosa, and we actually created a waiting list intervention called Motivate for people who are on wait lists, which sadly we hear in the media a lot at the minute that is the case for people with eating disorders. So yes, do take a look at our website. So this evening, how are we going to run things? As I said, we're going to do a little introduction. We're going to see from Alice and Dave how they're going to start this role play, and how they're going to interact with Alfie, and then you guys are going to get a chance to do that. And I think what I would say is that, we're all here to learn. I'm still learning. I still quite often get things wrong. So can we please just come with that kind of learning experience spirit? And there are no silly questions. It doesn't matter if you make a mistake. And I'm here to learn from you. I always learn from people that I train with. So let's just be really respectful, non-judgmental, and be really cheering one on this evening, because we're all here to learn more. How did this all come about? So one of my roles is that I sit on the Parliamentary Health Service Ombudsman's delivery group, and for those of you who don't know, there was quite a serious incident going back to 2012 when Avril Hart, 19-year-old student, died as a result of anorexia nervosa, and obviously it's local to the area, some of you guys are. 5 different NHS services had missed multiple opportunities to save her life over 5 months. In its 2017 investigation, the PHSO found that Avril's deterioration and death were avoidable, and that she had been failed by each of the NHS organisations involved in her care and treatment. Aspiring to ensure that no other family has to endure what Avril and her family experienced, PHSO noted that the majority of medical professionals have received little or no training on eating disorders during their education, and recommended that this be addressed. So the PHSO group, they came up with some recommendations, and I sit on the board, co-chair that group to ensure that those recommendations are met. And you'll see that really, once the investigation was done, it was then recalled back to Parliament through the Packet Committee, and we were reviewed in our progress on the PHSO recommendations in 2019, calling for eating disorders to be covered effectively in both the undergraduate and postgraduate medical curricula. So that was one of the strong recommendations. So this teaching package is therefore provided to enable medical education establishments to ensure that all medical students and foundation trainees are trained to understand, identify and respond appropriately when faced with a patient with a possible eating disorder. And it's the result of a collaboration between the Eating Disorders Charity, Health Education England commissioned it, and the Royal College of Psychiatrists Faculty of Eating Disorders. We were hoping the training was going to go live yesterday, but it's been a little bit delayed. So some of the information that you got through on your email, which was very dry and boring in a Word document, apologies for that, it's being currently finalised to be an e-learning module. And if you really want to go back and do the final whizzy thing, you can do. We'll make sure you get the links to the real deals, I should say. So what are the packages? So the training for medical students, 4th years, is a 30-minute e-learning module, the Word document that you got. And the learning outcomes were to be able to identify the major eating disorders and spot the early warning signs, understand the role of starvation in eating disorders and the effects on the brain, and understand common challenges experienced by clinicians identifying people with eating disorders. And at the end of the module, there's a fair bit of self-directed study for you to be able to read more. One of the best resources we would recommend is New to Eating Disorders. I'm sure Dr. Kieran, who's here, will mention that later because she was involved in that project. And then the foundation trainee, it has the same kind of structure, really, a 30-minute e-learning module, and then it's more about assessment and referral, physical risk and things like that. So just as exciting. Well, I'm hoping you've had a chance to look through some of the Word document. Like I said, it might have come across as a bit of dry and boring, but there were some pictures in there, but it gives you an overview of what you needed to know for this evening. Sophie, you just pop something in the chat there, and I would say please do put things in the chat if you want to ask me questions. So we've just been commissioned to release another training package, to write one for nurses. So we are working through the disciplines. This one's mainly for doctors, but we will be producing other packages as well. So watch this space. I still think you'll learn a lot from this evening by observing and looking at some of the communication skills that we're going to try and instill in you. So who is Alfie? Alfie is a 20-year-old man who collapsed at his university where he's studying sports science. He was brought by ambulance to the A&E department, and he's been purging and exercising excessively after consuming large quantities of food, mostly in the evenings and at night. So this has led to cardiac complications due to abnormal electrolytes caused by vomiting. He seems anxious and is reluctant to engage in any conversation, insisting on leaving the A&E. He explains that he's concerned about his horses at the stables where he works part-time and asks to be discharged urgently. So I'm hoping that you've had a chance to read through that scenario before you came, and hopefully you're kind of thinking around what would you be asking Alfie if you were assessing him or meeting him in A&E. But the main tasks that we want you to follow for this scenario would be to be able to take a relevant history to make a differential diagnosis and to explain the initial investigations required to guide the future management plan. You don't need to carry out a physical examination, but I'd love to see you try over this platform. Have we got any other questions? We do teachers training, absolutely. We do spotting the signs. We're just actually in the process of uploading all our training onto a pod, so it doesn't necessarily need to be live. You'll have lots of access to training, but sign up for the Beat newsletter, go to our website, and then you can be informed of any information around school training. Brilliant. So I guess, in this scenario, if you're coming to meet with Alfie, as Dr. John said earlier, I don't know whether you've had an experience of interacting with people who have eating disorders. In fact, it'd be really nice if you popped in the chat. I'd love to hear from you, hear actually what your experiences are, if you've had some. some of the feedback I get is that actually interacting with people with eating disorders can feel very scary. As Dr. John Wilson said, it can be so anxiety provoking. And I've just started this presentation by telling you that some people died. So already the anxiety levels are quite high, because this illness has the highest mortality rate of any mental illness. So I think it's good to put that out there, that there's anxiety around this, but I think there's also key things we know that work and ways that you can engage patients. So what things are we going to think about? We're coming to meet Alfie, and he'll come in all guns blazing. You just wait for it. I want you to think about them in how you're going to plan to do your own role play in the breakout room. I want you to think about, how will you approach Alfie in a caring, sensitive way? What are the key considerations in how Alfie is presenting that might be challenging? So you've got some clues, haven't you, in the scenario? He's keen to get back to his horses, he's keen to be discharged. Doesn't sound like he necessarily knows he needs to be there. So I guess it's going to involve exploring the possibility of an eating disorder for the patient's presenting issue. So he's come in, collapse, and how will you discuss the reason why he's presented to A&E? How will you ask about Alfie's symptoms of his eating disorder, and how might it feel for him to be asked about those behaviours? You know, we know that eating disorders are very secretive, can be very, you know, shameful illnesses. People hide them a lot of the time. So how are you going to evoke him and enlist him to communicate his issues? How we explore those predisposing, precipitating and perpetuating factors, draw on a family history of mental illness or psychosocial factors. And how are you going to explore biological and psychosocial factors, thinking through the personality traits of a person suffering with an eating disorder? So in the e-learning module, you might have noticed that some of the classic personality traits underlying eating disorders are perfectionism, low self-esteem. So you need to be thinking along those lines when you're coming to meet Alfie. And then it's important to look at the positive factors, isn't it, in Alfie's support network that you could think through with him. Any social stresses that might be exacerbating the condition, any presenting comorbidities. You would have seen from the e-learning module content that 75% of people with eating disorders have depression underlying. So we need to be thinking around that too. Can you think through and explore any physical tests that might need to be conducted? And we know that family involvement is really important in eating disorders. How might you encourage Alfie to engage the family in further discussions about management whilst maintaining that confidentiality appropriately? We're thinking about assessing capacity and risk, and how would you manage next steps and referrals treatment for Alfie? So whenever I come to this situation and this training, can you see how much there is to cover? And I think sometimes if this comes up as an OSCE or something, and you've only got however many minutes to assess a patient, I think this is why we really want space and time to explore communicating with someone with an eating disorder, because it's really hard to do it justice in a short amount of time. So let's go to the few bits in the chat and have a little look. Gosh, Tori, you might need to help me here.
Yeah, there's a
what
lot.
Have we got?
Yeah, there's a lot.
Is there a good summary? Can you give me a little summary of what we've got?
Well, Summer was asking if there are any opportunities to get involved, like volunteering as a student with BEAT.
Yes, medical student.
No, just university students in general.
Yeah, it's always worth an ask with our campaigning team in particular. So yeah, feel free to send us an email, because we have lots to be done.
Yeah, and just a lot of people kind of expressing that people close to them have had eating disorders, and they want to learn how they could kind of help.
And I'm so sorry to hear that. I can see some of the chat messages saying that people feel let down by services, and I think the sad fact is that we know there's not quite enough resource to go around at the minute, and we hope funding's coming, but actually a lot of what we do with BEAT is to try and develop that empathy with health professionals to engage with their patients in a more helpful way. And as Dr. John said, we try and get out of this kind of power struggle. I always think you can't fight control with control. I think it's about working collaboratively with patients. So I'm so sorry to hear that some of you have had some difficult experiences with that. I'd just like to highlight what Tori said at the beginning. You know, do take a minute if you need to. Some of this might feel a bit sensitive, but also think about, you know, ring the Beat helpline if you need to get some help for yourself this evening. Feel free to call the helpline, and it might be one of the best things that you do. So I guess it is time to introduce you to the one and only Dave Chawner. If he's going to ping up in a minute, I need you to put your video on, and the lovely Alice too. I'm hoping they're going to appear somewhere before my eyes. That would be really great.
So the platform only will show like maximum 2 people, so I will turn my camera off, and if Jess does, then we'll have Alice and Dave. I think maybe if we also stop sharing the PowerPoint for the role play, maybe.
Perfect, thank you.
Okay.
I'll switch my video off. So Dave, are you there, Dave?
I am here. How are you?
I'm good. I've switched. Oh no, maybe we are around. I'll keep my camera off. I'm going to be like the voice of God, appearing from nowhere but being everywhere.
You can keep it on, I think. Jess.
I can.
Yeah.
Lovely. Oh, this is good. And Alice, are you around somewhere?
Yeah, I'm here.
Oh, there you are. Alice, how are you this evening?
Good, thank you.
So, how do you want to start this? Are you happy to dive straight in? Do you want to give any explanation as to your thoughts approaching this in light of some of the questions I said? What would be helpful, Alice?
I'm happy to kind of jump in and see how we get on. Yeah.
Amazing. You're my hero, Alice. Go for it. Okay, Dave, are you ready? I will switch my camera off to see if you pop up.
Yeah, I think you can only get 2 people on at a time, so it's
Yeah.
sort of
Okay.
Okay.
So hi, is it Archie?
It is, yes.
It is, yeah. My name's Alice. I'm one of the final year medical students. Are you okay to have a quick chat with me today about what's been happening?
Yeah.
Yeah. Okay, so to start with, if you can just tell me a bit about what's happened earlier today.
It's really simple. I was just in a lecture. I stood up and I fainted, and I was brought here by ambulance. And to be honest, it's pretty bish bash bosh. Like, I kind of need to get going anyway. So yeah, it was just yeah, it was probably dizziness. I don't know. I'm not a doctor, but yeah, it's nothing big.
Okay. Well, it's a good job you came in today, so we can sort of give you a check over and see what's going on. Are you okay just to talk me through what happened at the time, sort of leading up to it? So I know you said you were sitting in a lecture.
Yeah, so the lecture, so I do sports science, and the lecture had finished, and I sort of stood up and I felt a bit dizzy, and then I kind of like blacked out, and look, everyone like freaked out because there's not a lot going on at the moment, and people are a bit bored. They've seen everything on Netflix, so they wanted a bit of drama and called an ambulance. And there's genuinely I don't need to be here. I just fainted. It's not the end of the world.
Okay. So I've just got a few more questions about sort of what happened leading up to that, just so that we can check why it happened and make sure we're not missing anything important. So before you fainted, did you have any pains in your chest at all?
No.
No? Any feeling like your heart's racing?
No.
Any weakness in any of your limbs?
No, not really.
No. And any changes in your vision at all?
Apart from passing out, no.
Okay. And when you did pass out, did you lose consciousness?
Yeah, so I was out apparently like 4 or 5 minutes.
Okay. And were there people around when this happened?
Yeah.
Yeah. Okay. Did they mention whether there was any sort of jerking of your body at all?
No, I don't think anything like that.
No. Okay. And a couple more questions. They might sound a bit odd, but you didn't notice any incontinence at the time?
No.
No. Okay. And how are you feeling once you woke back up?
Absolutely mortified. It's just very embarrassing. Like, everyone's there, like crowding over, and like, like I honestly, I'm fine. It was just a bit silly. I just got a bit dizzy.
Okay, so since then, have you been feeling much better?
Yeah, like, yeah, all right.
Okay. Has this ever happened before?
I'd say I sometimes feel a bit dizzy, but like he doesn't. No, but so no, I haven't passed out.
Okay. But have you had episodes where you've felt a little bit lightheaded?
Yeah, but yeah.
Okay. And is that normally when you're sort of going from sitting to standing, you can feel a bit dizzy?
Yeah, sometimes I just feel a bit woozy, like, yeah.
Okay. And how often would you say that that's happening?
To be honest, I don't really track it.
Okay. And you can't think of anything that normally makes it better or worse?
Not really, no.
Okay. So other than the sort of fainting, have you been feeling well recently?
Yeah, I mean, like everyone keeps on talking about sort of my eating habits and stuff. To be honest, I actually look after some horses at the stable, so I just really want to get back to them. And this isn't Ready Steady Cook. I'm not here to talk about recipes or foods or anything like that. I just want to crack on.
Okay. I can see you're quite keen to sort of get home. It'd be quite useful for us if we could keep you in a bit longer just to ask some more questions and check what's going on. So whether we can sort out someone else to check on the horses just for a little bit, so we can keep talking for a bit longer, if that's okay with you.
Okay, yeah.
Okay. So just going to back to what you were mentioning about the eating, some people had mentioned some things with that.
Yeah, I mean, like, look, I just said that I was running late. My alarm didn't go off. And I was running late to the lecture anyway, and it was a 9 a.m. So I felt a bit, rushed. So yeah, I skipped breakfast. Big deal, big whoop.
Okay, and that was this morning, was it?
Yeah.
Yeah. Okay. Would you normally have breakfast on a typical day?
I mean, not really, but I mean, it's yeah, not really.
Okay. So had you not eaten since, would it have been the evening before, or?
Yeah, like, well, yeah, bits and bobs, more in the daytime, but yeah.
Okay. I know they're quite sort of personal questions, but if you could just talk me through sort of on an average day, what your day looks like in terms of meals.
Well, it's about, to be honest, in terms of if we're talking about food, like I don't really like talking about it just because once I start eating, I find it very difficult to stop, and I become sort of like the cookie monster, just devouring everything in my path. So yeah, it's kind of like, look, it's probably a bit feast and famine, but whose isn't, like we've all got stuff on.
Okay. And is that been sort of a pattern for quite a long time, or is that something new for you?
Well, I suppose if I'm honest, it has been like increasing over time, and yeah, I suppose I am trying to lose a bit of weight, but it's just one of those things. It's no biggie.
Okay, so you don't see it as a problem at the minute.
Well, yeah, I don't. It's not that it's not a problem, but I just don't want. I just don't want. Like, I know if my dad found out, it's all going to go like mental, and it's just we don't need those dramas.
Okay. Well, just so you know, for the minute, it's a safe environment for you to talk here, and everything that you tell us is confidential. So if you're worried about sort of other people finding out, that's not something you need to be worried about, okay?
Okay.
So you mentioned that you have been trying to lose a little bit of weight recently. Have you lost any weight so far that you're aware of?
I lost about a kilo in the past week, 2 weeks.
Okay.
Which is good.
Do you know roughly what your weight was before?
Yes, but let's just like leave that whole thing. I just kind of want to, I suppose my mate Nick is very, I mean, Jesus, the guy's an Adonis. So just trying to, especially being in a sports science university, I mean, it's jock central, there's more pecs than there are IQ. So like, I'm still trying to sort of.
Okay. And how are you feeling about your weight at the minute? Are you happy with where you're at?
Who is? I mean, that's the honest, yeah, like, look, I don't like it. I mean, I have been increasingly sort of weighing myself, and sometimes I, try and push it to see how long I can go without food. But yeah, like, no, I'm not comfortable with how much I weigh.
Okay. So would you ideally want to lose more weight, do you think?
Yes.
Yeah, okay. And just a few more questions about your diet. Are you vegetarian or vegan at all?
Yeah, I'm a vegan.
Vegan, okay. And is that a new change, or have you been vegan for a long time?
About sort of past sort of 5-6 months.
Okay. And are there any specific foods other than the veganism that you would particularly avoid eating?
So, well, I find it hard to have like food in the house, so I just because I know that like once it's there, I just like get through it. So I just try and avoid sort of anything that's like in bulk, really.
Okay. In case you ate too much of it, is that?
Yeah, there was just like one night when I realized that I bought a 6-pack of crisps, and I got through all of them, and like the same with like a box of, there were like 7 or 8 breakfast bars, and I got through like all of them and stuff, and I just find it very difficult. And yeah, and it's embarrassing, it's just like, have some self-control, man.
Okay. And
I'm going to pause you guys
this
there. 1 second.
Mm-hmm.
Both of you are doing brilliantly. I just thought I'd kind of pause at this minute and just see how you're feeling, Alice, how you feel like it's going.
Yeah, I think it's okay. I think it's obviously quite like a sensitive topic for him, and it's balancing not pushing too much that he shuts off, but also pushing a bit further to get some answers.
Yeah, amazing. So I think some of the things that you're doing really well were, you said I'm going to have to ask some kind of sensitive questions, and could you see if anyone can check the horses for you, things like that, engaging them really well. Dave, how's it feeling for you as the patient?
Very uncomfortable. I mean, talking about this stuff is very uncomfortable. I mean, Alice is brilliant, and that's no testament to her. I think I started very angry, as a very angry little guy, but I think you're doing a brilliant way of that empathic and actually the active listening of like using my words back at me of like, okay, so I hear that you said that you're trying to lose weight. Specifically, what started that off? Okay, I heard that you said that, you lose control of how you eat. Can you give me an instance of that? And I think that's brilliant.
Amazing. So guys, whoever, if you're listening, feel free to put things in the chat, let Alice know what she's doing really well, and other members of the team, Ellen and Kieran, if you can look in the chat as well. Alice, do you want to keep going for another few minutes, and
Yeah.
then we'll regroup again and we'll talk about how we're going to go into breakout rooms. So another 3 minutes or so. Thank you.
Okay. So you mentioned when you've had these periods where you've been eating large quantities of food. Have you ever felt sort of out of control when this is happening?
Oh, like, yeah, loads. I think it's more because like in the daytime I'll try and sort of like reduce the amount that I eat, but then I find it really hard to sleep, and because I can't sleep, then I'll go eat something, and then once the floodgates open, then it becomes really difficult, and that makes me feel bad the next day, and then that sort of sets off a cycle. So yeah, I guess I'm just kind of scared of food. It just sounds ridiculous.
It's nothing to feel sort of embarrassed about. It's good that you're talking to us about it at the minute. Sometimes when people are experiencing sort of strange feelings around food, they might find that on occasions, especially if they want to lose weight, they might make themselves sick. Is this ever something that you've done?
Well, yeah, well, yes, I do, and I know that's probably not ideal, and I know my dentist started asking sort of awkward questions about that, but yeah, so yeah, I suppose I do, but it's not like, look, it's not a big deal.
Okay. How often has this happened in the past?
Well, I mean, in fairness, I think, yeah, like, to be fair, I think it's like increasing, but you know, it has increased, and especially this last week, because of going back to lectures and stuff, it's been a bit increasing. But it's normally like 4 or 5 times a week. I just know that this past week has been a little bit more, well, quite a bit more, just because I've been stressed.
Okay. And another thing that I need to ask about is sometimes people might use things like laxatives or tablets that can make you sort of get rid of water, like diuretics. Have you ever used either of those?
I bought some. I mean, apparently it's not that bad, so I wouldn't like. But I bought this thing called Movicol, and that. I mean, I've sort of started taking that, but like, you know, it gave me a bit of stomach ache, so I didn't use it that much.
Okay. And in general, how would you say that your mood has been recently?
I mean, it has been low, and well, I don't know, like it's just been very changeable, like very up and down, and I feel very erratic, and that kind of compounded with the dull like food thing. Yeah, it feels very like I've got nothing to like anchor me down.
Okay. I can imagine things at university can probably be quite stressful as well, if you've got a lot going on with your course. Have you got sort of friends or family or anyone that you normally talk to about how you're feeling?
I mean, like, to be honest, I'm not going to talk to people on the course about it for like numerous reasons. I mean, I'm the little dweeb that got in anyway. Like, I was lucky to be accepted into the course, and you know, no one's looking at me going, "Oh, he's a fit guy." So I'm not going to lower my status even further. And look, I don't really like having the slushy Oprah Winfrey chats with my friends. To be honest, that's just not me and who I am. So yeah, I can just sort this out myself.
Would you consider talking to anyone at home about it, do you think?
Absolutely not. Yeah, like I definitely. I mean, my dad is still in the 1930s, and you know, sort of man up, and I'm his lovely little disappointment anyway. Whereas my mom's got her own issues with food going on, so I might as well just stand on the rooftops and shout. So I'm not going to talk to my parents about this.
Okay. So in general, your mood has been a bit more up and down of recent. It's important for us to sort of check as well if people are experiencing quite a stressful time. Have you ever had any thoughts of hurting yourself at all?
I mean, so last week, just because I was really, really stressed, there was a lecture where we were in and I wasn't getting it and people found it really funny. And someone did see me using one of the, the sort of refillable pencils, and I sort of jabbed that in my arm until it sort of bled, and people, saw that and went, "Oh, what on earth are you doing?" And I have done that before when I do feel like everything's a little bit too much.
Okay. And is that a new thing that's happened, or has this been going on for quite a while?
I'd say that's a newer thing.
Okay. And have you ever seen anyone about that or the way you've been feeling?
No.
No. Okay. And have you ever had any feelings about wanting to end your life?
Yeah, I wouldn't say like that. I'd say like, look, without getting too deep, like, yeah, I've thought of like, this is not how I. Everyone always says like university is like the best time of your life, and like, Jesus, I'm like passing out in lecture theatres and digging pencils into my arm. I mean, Christ, I feel pretty lied to by the OC. So, yeah, I mean, look, things aren't ideal at the moment, but I wouldn't say I wouldn't say the S word.
Okay.
Okay, I'm going to pause you there. I wanted to keep going because I was absolutely riveted, because Alice, you managed to get him to this place of talking about such sensitive issues. It was like a masterclass, amazing. You'll have to read through some of the chat messages, but Alice, but some of the things that came up were, you remain neutral, judgment free. You're not giving any hints that you're concerned or worried about his answers, but also not verifying his statements that his eating episodes are normal, but also seeming understanding while still allowing the discussion to move forwards. Lots of feedback on skillful questioning, and yeah, open-ended questions, reassurance, following a structure, giving him time to speak. Lots of people saying they're learning so much from this interaction, and some people have said, I wish I'd met an Alice when I'd had an interaction with a health professional. So absolutely brilliant. Thank you so much. Dave, any other feedback from you?
Okay.
I think, yeah, just sort of absolutely echo everything you said. I think one of the things that you are so good at, and one of the reasons you are so good, is I think doctors always overlook this idea of rapport, especially in OSCE situations. And I do the OSCEs for the Royal Colleges as well. And in 5 minutes, it's really hard to build up that rapport, but it is absolutely key. If you can build up that rapport, you will, in the OSCE, get more out of the actor, but in real life, get a lot more out of the patient. And you are empathic, you are caring, you are listening. So I think you are a brilliant doctor.
Oh, thank you.
So everyone, we've had an amazing demonstration there. Once again, Alice, thank you so much for putting yourself out there and being bold. And it was just fascinating to watch your skills. So the next part of the evening really is, and Tori's put it in the chat, that we're going to be moving across to a different link, aren't we, Tori? And I guess when you go into these breakout rooms, I really want you to have a try at role playing. So obviously in that context, someone's going to need to offer to be the patient, and someone's going to need to offer to start doing some questioning. And I suppose really what I would suggest you do is kind of maybe pick up from where Alice left off, like in that kind of, you don't need to cover the same work and the same questions that she has done, or you can do. So yes, Tori's going to explain now. Tori, are you going to jump on and tell us how to get onto these the other link, or do we just meet over there?
Yeah, so Becky has kindly posted in the group chat the new link. So it's the same as this platform, it just allows us to have the breakout rooms. So yeah, if everyone just hops onto there, and we'll be staying on that link for the rest of the session as well, so no need to come back here. Yeah, so that's it.
We'll see you over there.
See you in a minute.
I've just acknowledged. I try and be like really, really honest and say, I'm feeling a bit uncomfortable that, you know, we're not talking. Is there anything that I can do to make it better for you? Or I'm worried that I've said something wrong or that's upset you. You know, would you like to talk about it? And if people say, no, I don't want to talk to you, fine. Like, they don't have to. Then it's not a prison. Like, people have the right to their, you know, you can't help people who don't want to be helped, right? So and you know, obviously there's discussions to be had around capacity and things, but you know, as a junior doctor, that's not my role. So yeah, I think just radical honesty and just saying like, I'm feeling uncomfortable. We're, you know, sitting in silence, and I feel like maybe you're anxious or upset. Do you want to, you know, can you tell me a bit more about that?
Brilliant. And I think, you know, so I was in group 1 and 13. Calvin, shout out to Calvin, because he was really going for it. He was doing the role play in our session, and it was almost like, how do you end the conversation? How do you get to the bit with the referral? Because like you can engage them, and it's almost like the bad news is coming of like you're going to need to approach it. Just wondered what your thoughts would be around that, taking that jump into, we've got to do something about this. Any thoughts? Feel free to put stuff in the chat as well, guys.
I'm going to nominate Kieran to answer this question.
Go on, Kieran. Go on, Dr. Kieran.
Hi. So yeah, no, I was just I missed out on the first part of it, although I did get to listen to Alice completely, and then I joined your group very briefly, Jess. But overall, what I feel is that the empathy and the sense of therapeutic engagement, I think was brilliant with both of them in the way that they were able to get to the individual behind the numbers. As I always think, you know, it's in eating disorders we do a lot of numbers, but how do you actually get to that person beyond the numbers? And I think that was done beautifully, very empathically. Yes, silence is to be respected as much as we can. Depends on the context. If somebody is in the A&E, we often don't have the privilege of time, and we have to do things quickly sometimes to keep people safe. So my default position is usually to go into their strengths, their resilience factors, like what sort of things do they enjoy? What was it like at the stables today or yesterday or whenever he went, and what is it like to be around this, you know, this beautiful horse that he's with, or what sort of things does he enjoy doing, and then get into that and then get back into it. So weave it in through some of those happy times and get back into the
I like that. So weaving in.
Yeah.
Very good. Very good. So we've got another question here on maybe some more information on what would happen when it's brought to attention that someone might be suicidal.
Yeah.
When would the mental health team be involved? When would the GP involved? So I thought that was a good question.
I can jump in here because I quite a lot of the shifts I do, that is my role. Tends to be someone comes into A&E and there's an identified mental health problem. We ask psych liaison or the mental health liaison team to come down and do a separate assessment, separate from a medical assessment. If it's felt that someone is suicidal, you risk assess it really. If it's, you know, low risk and people say that they can keep themselves safe at home, it would be you know, discharge home with a kind of safety plan where you ask people to you know, give people numbers to call, crisis lines, and come up with like a safety plan with steps they can follow, with like, you know, the top one being come back to A&E. If people are felt to be more high risk, where they need to be supervised, then at that point you would see if you can you know, keep them in hospital. And you know, the vast majority of people are happy to come into hospital, but it does happen that people refuse, and at that point you can think about sectioning people, but it doesn't happen very often. Like most people we are happy to discharge home because people live with people that they can be around that will keep them safe. once people have come into A&E and had a bit of a chance to talk out, actually that risk level goes down a lot. And I think the mental health team certainly tolerate quite a higher level of risk than perhaps I as a junior doctor would. So often I will ask the mental health team really for their, and people generally, but a safety plan essentially is something you'd go home with. And then with like GPs will follow up, so GPs can call people, every week, every day. And we've got community mental health teams who can go out and see people at home. So there is a lot of steps in between, being at home on your own, feeling suicidal, and being in hospital. There's a lot of services in between there that we can use. I've just seen a psych liaison or a joke.
I was like, oh, don't know where to go with that, really.
I have to say, certainly in the hospital that I work in, psych liaison are phenomenal. They work, they cover the whole hospital and A&E, which means if I have a patient on a ward who needs to be assessed, they will go to that patient as well. If someone comes into A&E, they see them as well.
Aww.
So
they sound brilliant.
The list of people that they have to see is very long, and it's a very hard job. But certainly everyone I know for a fact is trying their best. And most people who get into psychiatry are in it because they've got personal experience. So
yeah, that's true.
Yeah, I'm very sorry people have had bad experiences, and I can only apologise. Yeah.
Thanks, Ellen. So we've had another comment coming here, and I think the thing is with people with eating disorders, they can present in all kinds of situations, wards, clinics, can't they? So we've had a comment here really around actually someone's interacted with a child under section who needed tube feeding, and apart from supporting them, they've asked, what could I be saying to them or doing for them, which is an excellent question. Very distressing situation for someone. Kieran, any thoughts?
So I mean, it's a great question, and often, in very severe situations, perhaps on a pediatric ward or in an inpatient unit, you might absolutely have the situation, and there is no right or wrong. Well, the one thing is that you need to reassure someone and to say to the child to literally come down to the level of trying to engage them and trying to say to them that this is, at the minute, food is medicine, and that's the only way we can get them kind of out of this. And it's not always that the child's going to understand this. There might be ways of keeping them calm and distracting them through other techniques. Sometimes we've also had to use anything around them, including any sort of drawing material or TVs, getting their parents around them, getting anything that actually keeps them supported. But trying to instill hope and say that this is temporary, that soon they will be eating, and it's not something that's going to be forever. It's just a small way of getting their brain fed or their heart fed, or talking about the organs being fed rather than feeding them, because immediately it gets into, you feed me, I become fat. So you need to think about how the heart needs some nutrition to get pumping, or you talk about how the brain needs some glucose to sort of start thinking, and just get into that and make it more objective for them. And there are various ways. There's no, like I said, it's not black and white. You just work with the young person, but reassure them, be empathic, and instill hope.
And I think quite often when I'm working alongside, bit of feedback there. When I'm working alongside carers, what I say to them is that it's important that they're regulated themselves. If you come calm to a patient and you say, you can trust me, it's safe, I think that models that emotional regulation. So I think it's really important as a practitioner knowing how you're coming to a situation. If you're coming anxious, stressed, they'll pick up on that. If you want to learn more about that, Eva Musby, if you're not on mute, can I ask you to put yourself on mute? I'm getting some horrendous feedback. There we go, that's better. There's a lady called Eva Musby who's a carer. She was a carer of someone, her child with an eating disorder, and she's got this YouTube channel where she talks about explaining to a child who has to face a meal who has an eating disorder. It's like bungee jumping, and explaining that if you teach someone about bungee jumping, do you tell them all about the physics of it? Do you start, no, do you say, you can trust me, we know this, it's safe? And that's how she explains how you need to interact with someone who is really distressed around their eating disorder, because they're in threat, aren't they? So yeah, just calm, consistent reassurance can do a lot, I think. So the questions are coming thick and fast. This is great. Feel free to keep popping them in the chat, because we've probably got another 5-10 minutes left with our panel. What have we got? Any advice for bringing up eating disorders with friends and colleagues? How should this interaction differ from patient-doctor conversations? Yes. I mean, I think the things with eating disorders are that you will encounter them everywhere. When I recovered, I thought everyone had one, but that's not true. They're just very common. I would say if you're trying to engage a friend, stick to talking about feelings, not food. Don't go for the behaviours that can feel quite shameful. Ask them how they are, ask them how to open up about their feelings. But we've also got some good guidance on the Beat website around what to say and what not to say to a friend who you're worried about. So go and have a little look at that guidance as well, I would suggest. Any other thoughts from the panel on that one?
I think just on that one, like, building on your point of you sort of talking about feelings, as a bloke, like when I had my anorexia, I know it was really difficult because people say like, how do you feel about that? And I'm like, well, I don't really know. I don't really have that emotional vocab. I really like it when people say things like, on a scale of 1 to 10, 1 being rubbish, 10 being brilliant, what number do you feel? I think that's really useful to help sort of break it down. And equally, these kind of conversations don't necessarily have to happen in a sort of quiet room while wearing yoga pants, burning just listening to Enya. Like, it could be like on the way to work, in the pub when we get back to them, you know, on the phone. I think whatever's natural for you and that person, it actually tries to eradicate that loneliness that we have to talk about this in a certain way, and is treating that person like your friend who you've always known.
Yeah, I think that's a really good point. And I think it's important to remember that people with eating disorders are quite sensitive and can feel quite scared around direct eye contact. So actually finding other ways to communicate, walking alongside or in the car. So many people say, oh, I had the best conversations whilst I was in the car with someone, because it's not scary. They're not trying to read your emotion, check to see whether you're angry with them. That's an important aspects of communication with people with eating disorders. So here's a really juicy topic then. How much of a factor is BMI in the referral and treatment for eating disorders? Do we go there? Okay, you've heard of a few cases where people have been told they're not thin enough. Is this still happening even now? Who'd like to answer that one? I'm happy to answer it. I mean, the reality is that as much as, you know, we would champion at Beat that anyone should receive treatment for an eating disorder, it shouldn't be dependent on weight. It's a morbid preoccupation with food, weight and shape. It's a mental illness. The reality is, and I think COVID hasn't helped that we have had to prioritise treatment around the most severe and ill physically. So sadly, it shouldn't happen. It's not in the NICE guidance that it should be that way, but it is, and we are slightly underfunded, very underfunded in eating disorder treatments. But really, no one should really be omitted from treatment. And it's always good to go to your GP with the GP leaflet. So we've got all kind of downloadable features on the Beat website. You know, we really recommend through our helpline that someone downloads our GP leaflet and just go and hands it, because actually we're trying to break down that barrier of that interaction, impossible referral. Any other thoughts on BMI?
I'm sorry, Jess, I just, you know, I just can't be started on that one, because you know my thoughts on that, and you know, it's absolutely no way. I'm being a child and adolescent psychiatrist. One of the things is that we do not look at BMIs. We look at percentile BMIs, but even beyond that, we know that the atypical or the OSFEDs, which are the other specified feeding and eating disorders, are probably the majority that we see, and they are actually severe end. So they come with maximum risks because they are not recognized. They're not, the stereotype is absolutely non-existent now. We cannot go by any BMIs. You know, you could have so much of severity with normal BMI. So it's something that we have to go past, completely go past that.
Absolutely. And I think for child and adolescent support and eating disorders, the access and waiting time standard is quite helpful. So for those of you who don't know, young people who you are referred to an eating disorder service have to start treatment within 3 to 4 weeks of that referral, which is helpful. But with adults, we don't have that access and waiting time standard at the minute. Absolutely, Anna, you've mentioned Hope Virgo's dump scales. Totally agree with that. We're all in support of that here. BMI is definitely only one parameter for sure. I always think you can't measure someone's distress by what it says on the scale as a weight. You know, eating disorders to happen to people of all weights. So how does treatment differ from those that suffer from binge eating but aren't sick after they eat? So I'd really recommend that if you haven't taken a look at our Eating Disorders Awareness Week campaign, it was all about binge eating disorder last week. So we had a brilliant animation that we created, and we did that animation through a focus group. So all people with lived experience inputted into the week, and all the messaging that you'll hear from people with lived experience. So the treatment for binge eating is, the first line of treatment is guided self-help for binge eating disorder, and a really good book is called Overcoming Binge Eating by Christopher Fairbairn. And if someone isn't really able to engage with that, then it would be group support, kind of CBT as well. But actually the recovery rates using guided self-help are really quite promising. I'll try and put something in the chat about that if I can. I'm just aware we've probably got about 5 minutes left if there's anything else that people want to ask. I'm just going to look through the questions. One question about the role play. A question was asked about how much the man weighed. Is that helpful as a gauge to how severe the issue might be, or should it be avoided? Good question. Ellen's shaking her head. Go for it, Ellen.
I mean, how helpful is it as a gauge? I mean, I guess it's more helpful for monitoring rather than the like actual value. But I mean, we weigh everyone who comes into hospital as standard for drug dosing purposes. So, and I think beyond that, it's not that useful, but that's just my opinion. I mean, certainly in children, we weigh all children because when you dose drugs, you do it all on weight. But beyond that, in terms of how severe someone's eating disorder is, it's got no value or role at all, in my opinion. But,
Super, thank you. Sorry, I was just trying to post the link about Eating Disorders Awareness Week. How can you best support someone having an anxiety attack or being upset after meals post eating? Kieran, do you mind answering that one while I find the link for?
So that in itself is a very large topic of how you manage meals and how you support the carers or the family or the parents to be, around that person and that distress, because that's one of the main presentations or behaviors that you will find around eating, that the distress is centered around pre or post eating. And sometimes parents do say that it's most distressing to see their child like that. So how do you support parents in keeping the calm, the reassurance, the distraction techniques, trying to plan things of activities after food, trying to do food in any setting that is helpful to the child, and not being, we've got the carer skills book for parents, which I usually tend to show families, and it's a good one to have for everyone, all the carers, to try and support their children. And it's about keeping the calm, firm with the eating disorder, but kind with the person with it, if you know what I mean. So food is non-negotiable, it's something you have to have, but how about something else that we do instead, and what do we plan for the next bit? That's the way to do it.
Brilliant, thank you, Kieran. And this is my Overcoming Binge Eating book, which it's always very close to me. So yeah, do take a look at that as well. Overcoming Binge Eating by Chris Fairburn, very useful for supporting those with binge eating disorder. And actually, we are providing guided self-help at Beats at the minute. I think there's still some places available, so do refer on to us if you know anyone who might need support for binge eating disorder. Is there a different services? Are there any different services for boys and girls? Not a stupid question, it's an interesting one. No, there isn't. There aren't different services, but I would say, I think the challenge, Dave, come on, let's hear a perspective of male eating disorders.
Oh, I don't really know about that. I'm just a professional idiot. I mean, like I remember I went to, well, I've told this story that I went to a group therapy for people with eating disorders, and that's just because I'd just been dumped, and it was me surrounded by 14 stunning girls, and I was just like pouring my heart out, which turned into speed dating rather than actual sort of therapy. I've never really felt my gender come into play because I wouldn't really be described as like a manly man. But I think there are certain little things of like amenorrhea being, you know, the loss of periods that used to be in the DSM as one of the signs. And actually, you know what? I've never had periods, so I've always been anorexic. So there's little things like that, but we are getting better. I think that something that is really important to bear in mind is generally, and if we're going with gender stereotypes here, men can find it quite difficult in order to explain themselves. So I always think that analogies and kinesthetic thinking really works for me. So instead of saying, like I said earlier on, instead of saying, how do you feel? Like if you were a weather, what sort of weather would you be? Or trying to open someone up by motivating by fun. I once spoke to a therapist who said that they used to play on the PlayStation with one of their patients while they're talking. And I certainly know one of my mates who's going with a really tough time at the moment, he'll be beating me mercilessly on FIFA. And while he's like, you know, while I'm 11 goals nil down, that's when the real conversation comes up. So yeah, I think I would just sort of say the importance of distraction.
I do Lego therapy. That's very cool.
That's just the best that I want to. Yeah.
It was fine until we hit COVID, and then I had to work out how to sanitize each brick. That wasn't helping me. So we had to stop. We
had a ward iPad that had to go be sent away because it was just too difficult to work out how to deal with that.
Indeed. Whoever mentioned the Freddie Flintoff documentary on BBC iPlayer, very much recommend watching that. Absolutely. We had a question about Arfid as well, Kieran. I don't know if you treat Arfid in your service at all?
In fact, I am currently looking after a young boy with Arfid, and for everyone, Arfid is avoidant restrictive food intake disorder in DSM-5, and often, you know, it's one of those where it's hard to pick out, but there's a whole, you know, you can do a whole series on Arfid in itself. I didn't get the question, Jess. What was the question?
Any tips for treating Arfid?
So Arfid usually, obviously, nutritional restoration, because that would be one of the things to do. But also there's CBT-AR. So CBT for Arfid is something that is being developed. But alongside that, again, tailoring treatment to what the needs are. Sorry, I've gone. I don't know where I am.
It's all right. I think Tori's putting the slides up probably to suggest that we need to wrap up.
No. I was just, for anyone that did need to go, I was just leaving this here, but yeah, feel free to answer a couple more questions for a few minutes.
Perfect, thank you. Sorry, Kieran, carry on with your Arfid.
No, I mean, I was just saying how treatments are being developed as we speak. You know, CBTAR is known, but there are also others where you kind of, it's needs based, you tailor it to the person's needs and work along with it. But nutritional restoration, psychological therapies, emotional management, looking after anxieties, you know, because Arfid can be triggered by a certain incident. So you need to find out the basis of it and looking after the, you know, the contextual factors, support systems, all of it. So treating holistically, basically. But CBT-AR is the known one, CBT for Arfid.
And am I right in thinking, Kieran, that we haven't got Arfid in the NICE guidelines yet, though?
Well, it's not been commissioned fully for all services, but it will be very soon.
It will be
so
soon.
It will be included very soon in commissioning.
Wonderful. So there's been a lot of talk about Eva Musby, who I mentioned earlier. I also popped one of her YouTube videos in the chat if you wanted to look at that. I'm conscious, oh, there we go. Kieran's got it there. It's on my shelf too. Eva Musby, really worth looking up as well. I think we've got time for one question, which I think is a good one to finish on. As a medical student with an interest in eating disorders, how can we best get more experience and practice in this area? So I'm looking to Dr. Ellen and Dr. Kieran for that, and maybe Dr. Alice if she's still there.
I think Beat is probably best place for this. Actually, they're, like, you can become an ambassador. They've got a campaign on raising training for medical students. I would say do the training course that we've just designed, and I'll pop my email address in the chat. And yeah, just get involved with university societies. There's always student minds. Headucate sounds like they're amazing. And yeah, there's always stuff that we can do in medical schools, and yeah, become an ambassador for Beat. So
amazing, thank you. And what I'll do is I think I'll get Tori to send out, when we have got the link to the e-learning modules and the final training package, I'll get her to send it out to you guys. So today you've just had a flavour of that. Normally the session would be longer, and obviously you get the Wizzy e-learning modules as well. So I think we're going to wrap things up. I just wanted to thank my team in particular for coming along this evening. So, a huge thanks to Alice and to Dave for coming along, and then Dr. Ellen, Dr. Kieran as well. You've been amazing. And obviously, thank you, Tori, for organising this evening and just being a whiz with the computers and all the Blackboard breakout rooms and everything. It's been amazing.
No, it wasn't good. Thank you so much. So yeah, big massive thank you, and a virtual round of applause for Jess, Dr. Kieran, Dr. Ellen, Dr. Alex, Dave, Dr. Wilson as well. As everyone has kind of already reiterated, I think everyone's found this session incredibly useful, even people that have come that aren't necessarily maybe medical students or healthcare professionals. So yeah, I think there's a lot of interest as well in people getting involved more with Beat, maybe as ambassadors or med students looking for more experience as well. So I'm sure I'm going to be in touch with some more information from you guys. If anyone does have any more questions, I'm very basic questions, feel free to put them in the chat and we can try and help with that. But yeah, we've put feedback form together, just a really short one, if everyone could fill that out. So you can get there via the QR code, and Becky has also posted it in the chat. And if you fill that out, there's an option for you to select if you want to get a certificate that Jess has kindly signed, just to say that you took part in tonight's training.
I signed every single one.
Of course, yes, she did.
Can I get a certificate too?
Yes, you can have a certificate.
Sure. Oh,
Dave, do you want one?
You can all have one. I mean, yeah, go for it. And if there's anything that anyone you know, thinks we should have covered and we didn't, or anyone would like any more information, feel free to also put that in the feedback form. You know, we're always looking to do more things, and you know, there's always more that we can be doing. So just let us know. And again, like, massive thank you to Jess and the whole team for tonight.
Pleasure. And the other thing I'd say, if anyone's interested in campaigning around medical schools, we will be releasing some campaigns from Beats. We really need people to champion some of these training materials for us. We recognise the importance of getting them in to the medical training institutions.
Yeah, that's a good shout, actually. If you're interested in helping promote this training package that we've made, you can drop me an email or Jess an email, and we'll keep your name on a list somewhere, and we'll reach out to you when we need help.
Absolutely, yes. And there is more training coming. As I said earlier, we do training for school staff, so sign up for our newsletter through Beat if you want to hear more about it. And yeah, there's more training coming for nurses, OTs, social workers, all those disciplines.
Yeah, I think just more people asking about what they could do as like healthcare students that aren't med students or psychology students. I think kind of mentioned a bit before, but
yeah, I mean, we did run a training day called Beyond the Symptoms, which was for all kind of healthcare professionals. So due to COVID, we're creating this training hub. So we're trying to move all those sessions online into this big pod of all kinds of CPD training for eating disorders. So I would just say keep on the lookout for training bulletins, or you know, our newsletter through Beat, because as soon as that comes out, you can sign up for it.
amazing. There's a few people that I know from tonight that are interested in being Beat ambassadors.
Amazing. Yes, I mean, I haven't put my email address on, but you can send it out. Can you, Tori, to everyone? Where were they?
Yeah, I can do that.
And then, you know, if people want to get in contact about that, I can make sure they're forwarded on to the right people. Yes, big shout out to Dr. Ellen from Adam Rice. Absolutely, isn't she brilliant?